Okay, good evening, everyone. It's good to see you all. I'm John Moriarty from UCLA, and it's a real pleasure to be here with you for this webinar. We are just past the hour, and we have a stellar crowd of attendees, as well as a really incredible set of speakers for you tonight. And what we're going to be doing is discussing one of the most interesting areas in all of endovascular therapy, which I think is thrombectomy and large bore thrombectomy, and in particular discussing some clinical insights and real world experience with the AVENTUS thrombectomy system. This is a novel system with a lot of interest around it, new from Inquis Medical. We have many people who have significant experience now in the trials and in real world experience, and they're going to be sharing that with us here tonight. In a moment or two, I'll introduce our panelists. We really have a phenomenal panel here. But before I do that, I just want to thank everyone who's come on board. This is a terrific endeavor, kicks off 2026 in a wonderful way. Couldn't happen without the backing of Inquis and the leadership of the PER Consortium. And for those of you who are new to this, the PER Consortium really are the leaders when it comes to PE care, when it comes to education, dissemination of the newest and most up-to-date information throughout our space. So I really want to thank both those two partners, Inquis and the PER Consortium, for bringing us all here together. In a minute or two, we'll be starting off the program with an AVENTUS system overview from Dr. June Lee. I'll give an introduction to her in a second, but we're also joined by some really phenomenal panelists, including Dr. Sahar Sabri, Dr. Ripal Gandhi, and Dr. Rayoli. And I'll introduce them all in turn. But to start with Dr. Lee, she and I go back a while. She is a leader in the space. We're very grateful to have her with us, that she's an interventional cardiologist and endovascular specialist at the university hospitals, where she serves as co-director of the Vascular Center and co-director of the PERT. And then she's also an assistant professor at Case Western, all there in Ohio. After Dr. Lee, we'll go to Dr. Sabri, who's calling in from pretty far away this morning, showcasing how important it is for us all to be together. Sahar needs no introduction, but I'll give him one anyway. He is the Chief of Interventional Radiology at MedStar at Georgetown in Washington, D.C., and a professor of radiology there. He has a incredibly impressive pedigree from his time at Virginia, his involvement with multiple trials, and his leadership in the Viva and SIOR societies. And so really grateful that he's able to join us. Following on from Dr. Sabri is my long-time friend and colleague, Dr. Gandhi. Ripal is an expert from Miami Vascular, where he has one of the largest and most in-depth practices in all of vascular intervention. And he has been a colleague across many different trials in the endovascular space, and particularly within PE therapies, huge experience in both as a clinical trialist and in the real world experience when it comes to these devices. And this experience has been noted with awards from multiple different bodies, including the America's Best Physicians, America's Most Honored Doctors. He's a fellow of the SIR and of the Society of Vascular Medicine. And we're really glad to have Ripal with us today. And also from Florida, we have Dr. Ilan Rayoli, who is an extremely well-known interventional radiologist. He's a leader in VTE, and he's the director of venous thromboembolism at Palmetto in Hialeah there in Florida. He has been trained at some of the most premier institutions, mostly on the East Coast in New York, Harvard, and then in Miami. And really looking forward to hearing his experience when he talks about use of the AVENTUS in one of his case presentations. So after all that, without further ado, I really want to thank everyone who's joined us here. We have a huge crowd to kick off our educational and webinar endeavors in 2026. And Dr. Lee, I'm looking forward to learning from you about the AVENTUS system. Thank you very much.
Thank you for the introduction. Next slide. Next slide. Thank you. So really the design of AVENTUS really takes into account a lot of the unmet needs that we had currently in the PE space. Some of the inefficiencies that we noticed in large bore thrombectomy included very excessive exchanges in using the dilator and then switching back and forth between wires. Some of the wall latching that I'm sure many of you have experienced as well, where you aspirate and you think there's clot, but then you ultimately come back and it turned out to be against the wall. Prolong the procedures due to these inefficiencies. And then also the ability to really return blood very efficiently. That was something that we really desired in the catheter system that would allow some integration and allow the blood return a little bit more directly. So that's why AVENTUS came up with a catheter design specifically to make the procedure more efficient and really built for speed and optimization of blood return. Next slide. So first I want to highlight a couple of things. Number one is the catheter tip here. You can see on the right side of the slide is actually a slanted tip. Because of the slanted tip, there's actually no need for a catheter to be advanced with the dilator. The slanted tip itself actually then acts as a dilator. So there's no back and forth exchange with the dilator. In addition, ahead of the tip, what you'll see is a navigation tool that's also angulated and allows you to subselect into different branches of the pulmonary artery. Within the slanted tip aspiration port itself, there's actually a TrueClot proprietary sensing technology that allows the catheter to tell you as the operator, are you on clot, are you in free-flowing blood, or are you latched on a wall? And that'll allow you to understand, should I be turning the catheter, should I be moving the catheter forward or backwards to, again, make the aspiration more streamlined and efficient. And then we'll go over a little bit on the blood reinfusion system and how that works as you perform your PE procedure. Next slide. Here is the completely integrated inline blood filtration system. So as the clot comes into the catheter, what you'll see is that there's a TrueClot indicator here in the middle of the catheter, where it's highlighted by a green light here. The clot then goes into the aspiration syringe, which actually has a specific valve that only allows one directional flow. So the blood comes into the aspiration syringe, and then as you push the syringe, the clot and the blood then go into the clot filter, what you can see here. And the blood, the normal blood, then can be returned to the patient. The clot then sits on top of the clot filter. As we go through some of the case examples, you'll see how that comes into play in a real case. Next slide. In addition to the slanted tip, the advantage of not only not having to use a dilator, in addition, we can actually direct it to different locations. Here, what you can see in the upper panel here on the right side is that the tip of the catheter actually is facing the truncus anterior. So without having to actually introduce a catheter into the truncus, you can actually aspirate directly from it. Again, completely without losing your wire access, without having to reposition your catheter into a different branch. You can actually just leave everything into the right lower branches, turn your catheter, aspirate on the top, and then turn your catheter again, kind of more towards the posterior, the downward side of the pulmonary artery, and then advance it forward to retrieve clot from the right lower lobe. Similarly, what you can do after you perform this aspiration on the right side, here you can see on the bottom panel is that you can actually completely flip everything, including the wire, without having any exchanges, put the wire into the left lower lobe, and then aspirate thrombus from the left side. Next slide. And this is actually just an animation video showing kind of that TrueClot technology. Specifically, green means that you're in free-flowing blood. Orange means that you are touching the clot, and then blue means there's wall latch. And again, this is proprietary information that detects actually what kind of tissue the catheter is touching. Next slide. One of the advantages that I've seen personally is that when you advance the catheter, what you'll notice is that some of the changes in the color. So as you advance, sometimes you'll pass actually the clot. The indicator, light indicator will actually turn orange. You can do your aspiration. As you do your aspiration, the light will actually turn green. And then sometimes if you are wall latch, what you can do is actually turn the catheter a little bit, essentially to free it away from the wall so that you're not actively sucking down on the wall. So it really tells you a lot about your thrombectomy and how you're doing. So that gives you some feedback as to, do I really need to walk the catheter out, or is it purely just a wall latch situation? This animation actually shows you nicely where as the clot is aspirated, you'll see as it replays, there's orange, it turns green as there's only free blood. You push all the blood and the clot into this canister that I discussed. The clot ends up on top of the canister, and then the normal blood is then filtered out, and you can return it back to the patient. Next slide.
So thank you very much, June. And it's really a terrific appearance there of the integration between but the catheter technology, the ability to sense what's in front of it. Can you tell me a little bit about, in your practice, how much manipulating of the catheter direction are you doing when you're passing it through, say, the right or left main pulmonary artery? It would seem that having that side branch aspiration ability really is helpful when it comes to removing clot that maybe would be more wall adherent. But I'd love to hear your experience with that.
That's a great question. One of the, I think, primary advantages is that because of the directionality, you can actually utilize that to your advantage as you're passing through the right ventricle and through the PA. Because what you'll notice when you kind of get your hands on it is that some patients actually you require a little bit of clock action to really get that catheter through a bag URV, for example. So having that directionality actually helps a lot. Secondly, as you engage, what you'll notice is that you won't necessarily have to really go after different branches. Honestly, what I do is I park my wire in the right lower lobe first, and then I put the catheter in, again, kind of facing the caudal aspect of the patient. Typically do my aspiration from there. If the clot is actually more lateral, I face it more lateral before I do my aspiration. And then typically as I come back, I face it upwards towards the truncus, do my aspiration. And then as you pull back, typically the catheter actually directly goes straight into the LPA. So it actually naturally points there. And then it's pretty simple then to just feed even the versicore or a woolly wire into the left lower lobe, put your navigation tool over, and then your Inquis AVENTUS device over. I would say it's really simplified our PE procedures, actually to the point where I'm a little bit upset that we're not really engaging all those lobes anymore. So it's not as it's not as challenging anymore.
Well, I mean, you've always made it look pretty easy, but I'm pretty glad that it's less challenging. I'm happy with that. Obviously, we've got a bunch of questions for you. There's going to be a discussion later on about more in focus on how people approach individual cases. But one of the very good progresses over the last year has been in data in the PE space, and we've seen a lot of the questions that people have been asking over the last few years have answers now. And obviously, one of the big steps forward was in the AVENTUS trial. And I know, Dr. Lee, you led that trial with Dr. Sabri. And it's a real pleasure to have Sahir with us to be able to go over some of the trial data and an overview of that. So thank you very much, Sahir, for joining us.
Yeah, thanks, John, and thanks for Per Consortium for hosting this with Inquis. So can I go next, please? So we're going to review the pivotal trial, the IDE trial. I had the pleasure of being a national co-PI with Dr. June Lee. Was an amazing partner. This was to evaluate the safety and efficacy of the AVENTUS thrombectomy system for aspiration for acute PE. It was a prospective multi-center single-arm trial, and the subjects were followed at 48 and 30 days, 48 hours and 30 days. It was a diverse practice patterns. We had 120 patients and at 22 sites. Next slide, please. So next two slides. Subject characteristics at baseline. Basically, we had concomitant DVT was around 84% of the patients, and elevated troponins or BNP was around 88% of patients, and bilateral clot distribution was almost all the patients. Concerning these are all intermediate risk PE, and if you look at the modified BOVA classification, which looks at certain facts such as elevated biomarkers and heart rate, in addition to RV dysfunction, the majority, 87% of patients had advanced modified BOVA stage. So these were sicker patients. Go next slide, please. So concerning the procedure characteristics, the blood return, can you next, please? The blood return had was all the patients and almost all the patients got their blood returned. The blood loss was around 50 cc only, and no blood transfusion was needed. Concerning the device performance, I think Dr. Lee alluded to this, that once you pass through the heart chambers into the pulmonary artery, around 60% of patients did not require the catheter to be removed through the heart and outside the body. So this majority basically managed to be done by just a single pass through the heart, which is a very efficient way. And then the catheter dwell time was around 39 minutes, and only one patient required an adjunctive treatment. In terms of the pulmonary pressure, there was a significant decrease in the peak systolic pulmonary pressure and in the mean pulmonary pressure. Next slide. In terms of the efficacy outcome, the primary outcome was met, which was a 27% reduction in RV-LV ratio at 48 hours from 1.57 to 1.1. Next slide. Yeah, so we'll look at the clot burden. This was very impressive clot burden reduction. And we're seeing, this because of the efficiency of the system in removing clot. There was a 35.9% reduction in the refined modified Miller score with the significant removal of clot from both pulmonary arteries. Next slide, please. So concerning the safety outcomes, this was a composite rate of subjects with the device-related MAEs. There were none and met its safety endpoint. Concerning non-device-related MAEs, there were 3 cases, 1 major bleeding, and 2 clinical deterioration. And as we said earlier, there's no blood transfusion needed. Concerning the PE recurrence, there's only 1 case of PE recurrence at 30 days. Next slide. This is a very exciting part, and this is one of the main reasons I wanted to be part of this trial, because it went beyond just the regular measurement of clot burden reduction and RV-LV ratio at 48 hours. We've been asking repeatedly for more functional outcome data, and I think in this IDE trial, it was designed to look at 30-day outcomes and see that there's a difference from baseline. So I'm glad to report that this study showed a significant change in quality of life score for patients from baseline with a 25.3 reduction, which was significant in quality of life score, as well as change in 6-minute walk distance. And there was a 132.9 meter difference in increase in 30-day at the 30-day mark in 6-minute walk distance. So this is significant, and when patient talking about the walk distance and how it affects their life, and this is a significant increase in this functional outcome. So this was a very exciting finding that we looked at it and show that this device, this thrombectomy with this device, does actually improve functional outcomes. And this was the first IDE trial actually that looked at these set of outcomes. Next, please. So in conclusion, the AVENTUS pivotal trial met its primary endpoint for efficacy and safety outcomes. The clot was efficiently removed and blood was returned with no blood transfusion through 48 hours and a short length of stay. The functional status and the subject reported quality of life findings showed direction post-thrombectomy. Thank you.
Well, thank you, Sahir. Incredibly impressive results. And I might ask you 1 or 2 quick questions about them. Particularly, one thing that struck me was that these patients, they had a high BOVA score. They had a pretty poor 6-minute walk test at 48 hours. 245 feet is not a long way to go for these patients. We're expecting normal patients to be up in the 500 to 600. So can you speak to how that means that perhaps these patients weren't all intermediate low risk PE patients, which is always the kind of criticism of some IDE trials?
Yeah, I mean, I think this was, I mean, I think I would kudos to all the sites and the PIs and at the sites that, the patient selection was excellent. The majority were symptomatic patients. As I said, biomarker elevation was present in almost all the patients. So these were sicker patients, and their 6-minute walk test as baseline was pretty poor. And this tells us how much we can help these patients and show the difference and seeing the difference and with this being part of these trials and seeing these patients come back a month later and do the 6-minute walk test because as much as we try to do it in regular practice, we don't do it unless you're part of the trial to make it regimented. So to see that difference was significant. So yes, these were sick patients, and the improvement was significant, especially in the quality of life outcomes. Of course, as we all know, I mean, these patients also had anticoagulation. So how much of this was from the anticoagulation versus how much was it from the device or the combination of two? Well, we can say comfortably that the combination of this device with anticoagulation improves functional outcomes. And this is the conclusion of the study. And we know there's many other studies now looking at that and looking at this anticoagulation alone. The difference. We already have some studies showing that there's the addition of thrombectomy definitely adds to just anticoagulation alone. So yeah, sick patients and they improved.
Yeah, and that evaluation of functional outcomes seems to be incredibly important. We know that the mortality is obviously trumps everything, but in intermediate risk PE patients, you need enormous, enormous trials to be able to show that. And we know that improvements in their functional capacity is so important. The ability to take a patient who may have been in hospital for quite a while and then be functionally limited, and instead they get out of hospital quickly and they return to their normal life soon. That's a very enticing prospect, and it seems like the trial, your trial with Dr. Lee's, AVENTUS, is able to hopefully positively impact patients and make sure that they move along there. And one other thing that I took from it, and I'd love to hear your thoughts, is the bleeding seems to be an incredibly low. The blood loss is essentially negligible, 50 cc. I'd kind of argue, who cares about that?
Yeah.
And one of the criticisms of large bore systems has always been around blood loss, but it seems to be that this has been successfully mitigated in a large way here. And I don't know what your
Yeah.
thoughts are about that.
Yeah, I mean, I think this was an important aspect, and I think the lack of need for blood transfusion was something that we looked at as one of the secondary outcomes that was reviewed, and there were none. Yeah, concerning the blood return system, is a very efficient system. I think Dr. Lee showed that. I think you'll see it in some of the case presentations you're going to hear shortly. And it's a very efficient blood return system, not messy, and it's a very easy way to get the blood back. Yeah, so the blood loss was really negligible in this case, and I mean, this can definitely help in the patient's recovery when they don't have a lot of blood loss immediately after an event like an intermediate risk PE.
Terrific, and I look forward to discussing it more if we've time at the end. I want to keep moving because we have two excellent speakers who are going to run through some of the real life experience with AVENTUS case presentations. And I'd also remind people that if they want to ask any questions, please put it into the chat, and we have a terrific panel. We'll do our best to get to them. Next is my friend and colleague, Dr. Ripal Gandhi, who's going to be discussing a case presentation. Ripal, over to you. Thank you. And Ripal, I think you might be muted.
Can you hear me? Great. Thanks, John. First, I want to thank the PERC Consortium and Inquis Medical for allowing me here to present. I also want to give a shout out to my partners, excellent techs and nurses, and finally, our awesome rep, Barbara. Without this, would not have been possible. So we're going to go and launch it in the case. And, we heard some really, great clinical data from Sahar, but I think, this is our very first clinical case that we did. And I think the real world experience is even better than the clinical data that he presented in this case. So I'd love to share this with you. So this was a 62-year-old gentleman who presented about 2 weeks ago, came in with a history of hypertension and just had embolization of a dural venous fistula at an outside hospital a few weeks prior. Presented with cough, chest pain, and shortness of breath. You could see he was tachycardic at rest. Heart rate was 108, normotensive. However, just with minimal ambulation to the bathroom, his heart rate jumped up to the 130s. Oxygen saturation dropped to 87% while on a couple liters of oxygen. His oxygen saturation wasn't really great at rest either, it was about 90%. He had elevated biomarkers as well, elevated troponins and proBNP, as you can see. But the most concerning was he had elevated lactic acid, as we all know is a concerning factor and has been associated with increased morbidity as well as mortality in patients with pulmonary embolism. Can we do the next slide, please? You can see there's a large central pulmonary embolism here, which extends into the more distal branches. You can also see there's evidence of right heart strain with an increased RV to LV ratio. Next slide, please. We utilize, some of this AI technology, which is really great. Allows us to get this patient information before anybody's even looked at the CT scan. So we get these alerts all day, and you can see this patient has an RV-LV ratio of 1.6, again compatible with right heart strain. Next slide. We went on to get an echocardiogram, which shows what you would expect to find here: dilatation of the RV. There's moderate reduction of the RV systolic function. And this was read as mild pulmonary hypertension with an estimated RV systolic pressure of 40 millimeters mercury. And I'm going to show you how that kind of correlates or doesn't correlate to what we actually saw invasively. Next slide, please. So we're involved in multiple clinical trials, and that's always our number one priority. And we just did discuss the clinical trials with this patient, but he did not want to participate. So this was our standard access. We got right common femoral vein access. We had already excluded any DVT in that leg. We always get a venogram first to make sure that there's no central iliac or IVC thrombus, which we might have to address prior to addressing the pulmonary embolism. So this was clear. Next slide, please. After catheterization of the right pulmonary artery, we did an angiogram here. You can see a large clot in the right main pulmonary artery, as well as within the right truncus anterior. Next slide. This was the pulmonary artery pressure, and I initially didn't believe it. This guy didn't have any history of pulmonary embolism or any other cardiopulmonary issues, which would be suggestive of chronic pulmonary hypertension. I re-zeroed it. I checked another line, but this was really the pressure. It was 82/27 with a mean of 49. Pretty remarkable. And with our experience with other devices, there's really no issues putting a large bore device. I've never had an issue in patients with pulmonary hypertension with the large bore device. So we went ahead and introduced the AVENTUS device. Next slide, please. So this is the introduction of the device. Number one, this was my very first case here. Done cases afterwards, but it tracked very, very easily. Number one. Number two, it has this directional aspiration on it, and it is very, very torqueable, as you can see here. You could rotate it very easily. Next slide, please.
Ribal, can I stop you for 1 second? Because there's a question in the chat, which I think would be, goes back to your previous point. What is the typical guide wire that you're using for access through the heart or for delivery of the AVENTUS system? And did you use a sheath here as well, or no?
Sure. Yeah. Typically, the way we do these, we typically get access with a standard sheath. Usually a 6 French sheath. We use an angled pigtail catheter to cross the heart. I do like a tip deflecting wire, although you could utilize the back end of a Benson to get across the heart as well. It's a cheaper way, but I do like a tip deflecting wire to get into the pulmonary arteries. But once we're in the pulmonary arteries, the way I approach these cases pretty much every single time is I basically take my pigtail catheter, push it as far as it'll go, and then use a 1 centimeter tip Amplatz wire and basically allow it to curl back on itself. I think that's the safest way of doing it. A lot of people will select little branches of the pulmonary arteries. I think I think you could end up with the issue there. So you put in a 1 centimeter tip Amplatz wire and subsequently advance the device over that guide wire. I think one of the things with this device, once you have the device in place, you can go to a softer wire if you want, which is probably not advisable with some other devices.
Gotcha. Thanks. Terrific insight.
This was, really discussed very nicely by Dr. Lee, this true clot sensing technology. And, I never utilized this before. Oftentimes they'll show you things and I'm not really sure if it's going to really work when you put it into a patient. But, again, the green is when you're free flowing blood, orange when you're on clot, and blue if you're up against the wall. And again, this allows for more efficient thrombus removal. You're not dealing with a lot of empty thrombus removals, wall latch lollipops. It decreases your empty aspirations, as I mentioned, and allows for reduced contrast utilization. But does it really work? So go to the next slide, please. This was the very, very first aspiration. You can see orange there. We went ahead and connected the system here. And very, very simple. We pulled back on the syringe here because you got some blood here, then push down on this button and push the blood forward into the filter here. And you can see with this very first aspiration, we got a bunch of clot here. Next slide. So here we got blood here. In terms of returning the blood, it's very, very easy. All you do is you disconnect and connect it to the sheath and reinfuse. So you're really minimizing the number of steps. You don't have to go to the back table. You're not utilizing any other system. It's all connected, and it just allows for much more efficient blood reinfusion. And it's there's only one other system on the market that allows you to reinfuse the blood. Next slide.
Wow.
And this was the first pass thrombectomy.
Wow, I didn't even appreciate how much clot was in it. This is incredible. And then to what this thing?
So you're making it look very easy, Repal. Obviously, a learning curve exists with any device. Can you speak to a bit how intuitive it is? Is there a lot to learn when it comes to putting it together? How did you find that?
Yeah, this is our first case, and honestly, it was, if you were to ask me how many cases does it take to feel comfortable with this device, I would say one. I felt very, very comfortable after the first case. The first case, there's always, every time you use a first case, you have to, how do you filter it? You saw how easy it was to clean the filter here. It's so easy to reinfuse the blood. So really, honestly, there's not much to it. I like things which are intuitive and easy, and this is it. Next slide, please. This is where, again, here we're in green, we're in free-flowing blood, rotating the system here. And what I like here, you have one-to-one rotation of the catheter tip on the directional aspiration on this bevel tip with one-to-one. And as Dr. Lee mentioned earlier, you could, basically, turn it up towards the truncus anterior. You could almost do like a drive-by aspiration on the truncus anterior, which is very nice. Next slide. And then again, blue, if you could play that video, please. You can see it's initially green here on free-flowing blood. And now it's blue. So we're up against the vessel wall here. And we're probably up against, the superior part of the pulmonary artery here.
So when you saw that blue, you released the suction and let presumably the wall kind of fall away. Is that the general idea?
Yeah, I think there's a few different ways of doing this. And again, that's one way, or you release the suction, or, I don't think you're going to really cause any issues. You could just basically turn the catheter in a different direction. You're not going to cause any damage there.
Yeah.
Next slide. And this was, now again, keep in mind that this is our first case, and I did multiple aspirations on this device, probably 3 or 4. I only removed clot on that very first aspiration. And I was doing these additional aspirations because I was new to the device. I wanted to see if this true clot detection mechanism actually was working, and it was. I only got orange on that very first aspiration when it was actually in clot. I subsequently was only getting green and blue. And, pretty good result here. There's still a little clot you could see in the more distal TA. Probably could have done another aspiration exactly where the catheter is now. I wonder if it had enough aspiration power to remove the more distal clot, but I felt pretty comfortable with this. You can see that there's much better perfusion in the right lung. Next slide, please. Again, pre and post, you see marked improvement here. Next slide. In terms of going from the right lung to the left lung, very, very easy. Basically, you just pull back the catheter, the guide wire, and the catheter here. And with a lot of the other devices, you might have to reintroduce a dilator here. You really save a lot of time here. all you have to do is just advance the guide wire and catheter that you already have in there. Also want to notice that I really don't have that much catheter and guide wire out. It's not buried way distally into some small segmental branch of the left pulmonary artery. And yet the device tracks very, very well, as you can see here. Next slide. And this is an initial pulmonary angiogram here we did with a lot of clot here. Next slide. And this is just to show you that one-to-one rotation of this directional aspiration tip. So what's really nice for the left pulmonary artery is angle the bevel tip inferiorly when you're attacking the main pulmonary artery here. And if there's some clot in one of these more superior branches, just turn the device superiorly, and it works really, really well. And I think it's really, really well designed for the left pulmonary artery. Next slide.
Look at that. Beauty.
And this was with a single aspiration. And similar to the right side, I did a couple additional aspirations just to, I hadn't done any runs in between. Again, I'm using a new device. With any other device, I'm doing multiple aspirations until, I feel really comfortable with, and I feel like I got most of the clot. But I only got clot out on a single aspiration on both the right and a single aspiration on the left. Next slide. In this blue port here, you utilize it to do a run. I usually like about 20 cc's of contrast followed by about 30 cc's of saline. But the other nice thing about this device is you could take a pressure line, and keep it on there during the entire procedure and have real-time pressure measurements. So, one of the endpoints that we always talk about is, we're obviously looking for thrombus removal, better perfusion, improvement in hemodynamics if they're off, but also you could utilize real-time pressure monitoring, which I think could be extremely valuable. Next slide. And this is this was after that single aspiration. You can see there's still some clot in the more distal PA, and this device I think you could definitely track down there. Patient was getting a little antsy at this point. His back was hurting, and I kind of wanted it to be done at this point. I did another main pulmonary angiogram. Next slide, please. Pre and post, marked improvement here. Next slide. And this is a final PA pulmonary artery angiogram. Again, you still had that little clot in the distal TA, a little bit in the left lobe pulmonary artery, but marked improvement in the flow. And next slide. Most important to me here is pressures. I've only seen this a couple times in my career to have this significant of a pressure drop. I mean, this doesn't happen every day, but this was real, and I double checked it. I checked it with several, re-zeroing it and checking with another line. We had over a 40 millimeter drop in the PA pressure. So as I said, Dr. Sabri showed some really nice results from the trial, but this patient, beat all those results. Next slide. And this was a post-procedural echo, which showed a normalization of the RV size and function. Next slide. And we did a CT pulmonary angiogram 2 days later. A lot of this was maybe more for me than for the patient. But you can see there's resolution of all the central PE, normalization of the RV-LV ratio. There's still a little distal clot, but nothing to be concerned about. Next slide. Again, pre and post. Next slide. But most importantly, clinically, his symptoms completely resolved. We did a walk test. He was no longer tacking away in the 130s. His heart rate was 98. His O2 saturation was 96%. He had a marked improvement in the PA pressures, as we talked about. Blood loss was about 30 mLs, and that clot detection mechanism really worked. It was truly only 2 aspirations, one on the right and one on the left, where I actually removed thrombus. And patient has done very, very well, was discharged from the hospital a day after that, 2 days later after we did the CT pulmonary angiogram. Next slide. I think I'll stop there.
Yeah.
And I'll have to take any questions at any point in time. Thank you.
Well, thank you. I mean, hugely impressive. And one thing that I always struggle with, and I know that we've had many discussions of it, is when do you stop with these aspirations? And what it seems to me, and I'd love to get your opinion, is this gives you a lot more potential endpoints, that you're getting feedback on a couple of different metrics, some continuously, some before or after a single aspiration. And I'm not certain where you will land with your next case as to what's the most important, but it would seem to kind of all allow us to perhaps end earlier and not do unnecessary time in the pulmonary arteries. I don't know what your kind of opinions on where we're going to end up are?
Yeah, I think we're gonna be able to do this much faster. We're gonna be able to know whether we're on clot or not. I give credit to my rep who I've known for many years, and she kept telling me, "Hey, why don't you do an angiogram, man?" I don't, that's not my experience with other devices. We use a lot of different devices, and I'm usually in there doing a significant amount of thrombus removal before I want to do a pulmonary angiogram. But in this case, it truly, truly did what exactly it's supposed to do. When it was on clot, it was on clot. When it wasn't, and you could check your pressures real time. So I think it will allow for more efficient procedure, less contrast, less radiation, and getting in and out faster.
And overall, how long would you say that procedure took you?
That procedure took a little bit over an hour. I don't remember the exact time, but keep in mind, a lot of this was, playing around with the device, understanding how it works, playing with it. We subsequently, like a couple of days later, did another case with a patient who was like doing really, really poorly, clot with a clot in transit, and we got in and out of that case very, very quickly, and treated the clot in transit as well. So I think it really allows for very efficient thrombectomy and makes the procedure faster.
Well, fantastic. Well, thanks so much. And I have a bunch more questions around, how you approach it and what you're doing with the groin, but maybe we'll talk about that after our next case presentation. And also coming from Florida, Dr. Aioli, it's really good to have you here. Thanks so much, Elon. And I look forward to hearing your case as well. Thank you.
Well, I want to say thank you to the panel, distinguished panel, and thank you to the PERD Consortium and AVENTUS and Inquis for having me here and being in such illustrious company, with the exception of Dr. Gandhi. So I'm going to go ahead and present a case here. This case to me is, next slide, please. It really summarizes why this device is so important and why I think it's going to be a game changer in the PE thrombectomy space. So I had a female. This was about 3 months ago. We had just gotten the device approved. Female, early 70s. She had a horribly displaced fibular fracture about 4 days previously, and she was scheduled for surgery in 4 days. And she was at home. She became severe short of breath, could not get up, and fainted. She was brought to the ER. They suspected PE right away. Good for them. They did a CTA right away. And if you can see, there's not a ton of thrombus here. If we'll go back to it as we cycle through it here, it's not like there's a saddle embolus and there's massively occlusive clot, but wherever this clot is, it's well placed to cause bad symptomatology because it's occluding multiple segments. And so it's almost acting like a large central clot. And so this was, of course, and the patient presented with blood pressure of 78/53, her heart rate over 150, all the biomarkers positive, including lactate, hemoglobin of 98. No, that's not correct. It's actually 9.8. So just want to see who was awake. But anyway, so she was classified, we risk stratified her to massive pulmonary embolism. This is for these kinds of patients, we do emergent mechanical thrombectomy. We usually advise the ER or ICU to do systemic thrombolysis first if the patient is really ill. In this case, they didn't want to do it because of the fracture. Next slide. So due to the hemodynamic instability, due to the fact that we had just gotten the device, I hadn't even used it, I decided against using the device and went with something I was comfortable with, something our whole team was comfortable with, because we wanted to be in and out of here as quickly as possible. So we went with another 24 French thrombectomy device, which we had a lot of experience with as our initial tool to treat this patient. Next slide. So This says a lot here, but basically our index procedure, we did a right pulmonary angiogram. So the way I do this usually is I use an angled swan to cross the heart. It's a 7 French angled swan, and the beautiful thing to me is that it just has a habit of flopping into the right PA. And sometimes it can be really hard to get into the right PA. And this one magically goes there almost every single time. So I love using it. It's great to cross the right heart. So I got into the right pulmonary artery. I did an angiogram. It showed complete occlusion of the right upper lobe of the TA, basically, which the CT did not show. So you can see that clot does shift around. That's why I think it is important to do a pre-procedure angiogram for these patients. And there were multiple incomplete emboli in the middle and lower lobe. So this 24 French catheter, we advanced it in the RPA. We did several aspirations. We got clot out. I was going to take a completion right pulmonary angiogram, so I moved my catheter back a little because I wanted to include the TA, and the catheter flipped into the left PA, which we've all had happen. Unfortunately, this catheter had the 1 centimeter amplats sticking out about half a centimeter, and it must have ruptured something because the patient immediately began having agitation and discomfort, and I, I was suspicious that something may be wrong, but then she felt okay. So we decided to go on with the case. The catheter was in the beginning of the left pulmonary artery. So then I advanced my guide wire. I took out the 1 centimeter tip amplats and I put in a stiff glide, which is what I like to use. And the stiff glide went straight up past the left pulmonary artery, up around the aorta, crossed the other side, and came down to the right side of the superior vena cava. So I knew at this moment that I had not just a pericardial leak, but a mediastinal leak, and this is when my sphincter just tightened. I immediately took my ultrasound probe, put it on the heart, and it just showed a lot of pericardial effusion. We immediately placed an 8 French pigtail. We got out 1 liter of blood, and I was going to call it and say, that's it, we're done. Thank God, the patient did okay. We transferred we closed the groin, we transferred the patient to the unit, and I was going to say, that's it. Next slide. Went to speak with the patient. She did great overnight, went to speak with her the next day, and she was still tacky. She was in the 130s, blood pressure not normalized in the 110, 120 for her. Her normals were 130 to 140. Her biomarkers were still positive. And she had a 2D echo, which still showed RV dilation and tricuspid regurg, which is surrogates for elevated PA pressure. And then she said the words that break my heart. Doctor, I trust you. Go ahead and do it. Whenever that happens, you're like, oh no, something bad is going to happen. I spoke with the ICU docs. I spoke with her pulmonologist, the cardiologist. So we all made we made the decision that we're going to go ahead and try to treat the left. But I thought maybe this is a good time to bring in the AVENTUS. And next slide. Because I felt like with the AVENTUS, I didn't have to use a stiff wire. I could get up there with a very floppy wire, and in fact, I used a Benson, and not worry about re-injuring the pericardial space or the pulmonary artery. I could get in and out very quickly, hopefully do 1 aspiration, and that's it. I could precisely target the eccentric thrombus that we saw in the left upper lobe and lingular branch and the left lower lobe of one of the fast procedure as possible. And I didn't want to just sit there and aspirate and drop the hemoglobin even further. And of course, if the blood clot identification system worked, that would be a bonus too. But I didn't really believe in it because I've heard these things before, right? So, next slide. So we did bring out the Aventus. I crossed the right heart. I did a right pulmonary arteriogram just to make sure that we were, because I didn't do one before the case the day previously, and we had cleared out all the clot. I did measure pre-pressures, which I didn't yesterday because when it's an emergency, I usually don't. And then the pulmonary arteries were still elevated. The pressures were still elevated, not badly, but it is elevated. Her BP was still low for her, borderline tachycardic, 98% SpO2 on 6 liters. So still had some problems. Next slide. That's the LP angiogram. I'm sorry, can you go back to that slide? I forgot to. So here we can see that we have no perfusion of the left lower lobe, and we have spotty emboli in the lingula and left upper lobe. Next slide. So the way I thought about this is I'm gonna try to do the entire procedure in one pass. And so I'm going to use the directionality. I'm going to put the Aventus catheter down in the left lower lobe. I'm going to point posteriorly because it just, it's my luck that the posterior branch of the left lower lobe has most of the clot. Most of the time I do these procedures. So I'm going to point posteriorly and start aspiration. And as I pulled back, I was going to turn the mouth to face laterally, to face the lingular branches and the left upper lobe branches, and try to remove everything in a single aspiration. So that was my goal, right? So, but I really didn't think I'd be able to do it. We took the Aventus down. I brought it down to the left lower lobe, and then I did see orange, so I was amazed. I performed the aspiration, and I did exactly what I wanted to do. I slowly pulled the Aventus back until I got, and then I turned it laterally, and I pulled it back to the left upper lobe until the syringe filled, and then I pushed it forward, which emptied it into the filter. I looked in the filter, and there was a ton of clot, and I said, "Is that it? I mean, that can't be it." The next slide. But we decided to do an angiogram, and boom, a single pass removed all visible clot. I mean, I'm sure there's a little bit left, but it looks like most of it is done. Next slide. And her heart rate stabilized. She was back down to the low hundreds and in the 90s. Her blood pressure normalized to her usual. She had a follow-up CT a day or two later, which showed complete resolution of clot. Her RV-LV ratio normalized. It was 2.0 before. It normalized to 0.8. Her pressures came down. They were not that elevated to begin with, but they still decreased. 8 points the systolic and 7 points in the mean. Estimated blood loss, I mean, I'm saying to less 20 cc's, but it's probably less than that. 2-minute thrombectomy time, literally, I mean, with a catheter down there. And we completely treated this patient, and we prevented another major adverse event. After this is the case that just, it really blew me away, because the clot sensing to everything that was promised me in this device came true. The clot sensing technology worked, the torqueability worked, the targetability worked, and the single thrombectomy pass, was true. So I was amazed, and I continue to be amazed daily with this device. So thank you very much for everyone for your time. I appreciate it. And thank you, Inquis.
Well, no, thank you. And thank you for sharing a crazy case and a phenomenal outcome in someone who was very sick, and makes me want to make sure that I get one of those giant, whatever that is, poster that you're holding up there for when I do my first case. This is really impressive. Thank you so much for sharing it. And, we have only a few moments more together. But we've a huge crowd on the line here, really indicating the intense amount of interest in PE, in PERT, and in the Aventus device. Let me maybe ask a question for Dr. Lee. June, we know that PE is incredibly common. There's 900,000 or so cases. It's, the third leading cause of cardiovascular mortality. Everyone knows this. And we know that there are patients who are either going to die because of it or they're going to have severe impact if they survive. Where in your practice now, with a kind of a PERT evaluation of your standard intermediate high-risk PE patient, where is the Aventus device kind of coming in your own practice?
Well, I will say, actually, the majority of my cases, like 99%, are now going to Aventus. And the other aspect is that one of our newest faculty, Dr. Tashtish, who's on the call actually today as well, that we just trained last year, has loved this technology so much. He's 100% utilization of Aventus. So I will say that it's very user friendly. So even new users, new graduates, new fellows coming out into practice, a few months in, he's doing all kinds of crazy stuff. He's doing clot in transit. He's doing RA thrombectomy with this catheter. So I think it's so user friendly and so intuitive that once you get your hands on it, you will equally feel that it's probably going to supplant everything else.
John,
Okay,
can I
well, I mean,
just
that's
add
about as
quickly?
ringing an endorsement as we can give. We only have a moment left. I'd love to go around the table, give everyone a chance to give any closing remarks. Next on the screen is Dr. Sabri. Sahir, anything you would like to send us away on?
Yeah, just quickly, I just want to, concerning the ease of use, in the trial, the plan was to do roll-ins and basically to have a significant number so that each site will be comfortable before actually enrolling in the pivotal trial. And actually only 9 patients, or I think 10 at the most, actually were roll-ins, and they just went directly into and felt that there's no actual need. And the majority of sites did not do roll-ins; they went directly into the trial. So I think that for us was something that was ready for that aspect of it, but actually the ease of use allowed us to. I think the support from the company as on the field was good. That the ease of use you don't need, and I think already it was mentioned a couple of times by Dr. Gandhi and Dr. Ruola that it was ease of use. It's intuitive and you can get going with it pretty quickly.
Well, thank you. Yeah, it really speaks to the learning curve or lack thereof. Ripal, what are your thoughts as we come towards the close?
Yeah, with these procedures, my goal is to get in and out as fast as I can. We want to do it safely and efficiently. It's the only device on the market that has both the ability to reinfuse blood and clot detection, which I think, you don't have to pick and choose a device that, only has one or the other when you have a device that has both. I also really like the real-time pressure measurement, the trackability, not needing a dilator when you're re-advancing the device, and the directional aspiration, the ability to just turn the catheter. And for the left pulmonary artery, I think it works really, really well by just turning the bevel downwards. For the TA, you just turn it upwards. So it really gives me, a lot of the things that I think we're lacking and allows for a much more efficient procedure.
Well, thank you. And Dr. Rioli, you presented a phenomenal case. I'll give you the final word here.
I think if you've used a 24 French thrombectomy catheter, even a 20 French thrombectomy, even a 16 French thrombectomy catheter, you will find this easier to use than anything else out there. If you've never used any thrombectomy catheter above an 8 French, then you may have your hesitations about it, and your tech will walk you through it because that's another thing about this company is that the techs tend to be very well educated and very, very good at their jobs. I really highly recommend this, and I truly believe that it's moving the field forward.
Well, I think that's a wonderful place to stop. I really want to thank everyone on the panel. It's been incredibly instructive for me. I've learned an awful lot. I really want to thank all of our guests who've called in from all around the world. So morning, good night to everyone. And thank you again to the PERT Consortium. The PERT Consortium is the leader in this field when it comes to education, dissemination of the all the knowledge to help your patients. And so if you are involved with PERT, please continue to have it as a big part of your practice. And if you're not involved, there are so many ways to become involved with PERT International, with PERT Partners, and with the PRISM program. So I really want to thank you. I want to thank Inquis for supporting us and for educating me hugely tonight. And with that, thank you very much. Good night. All the best.
Thank you.
Thank you.